Okay, I'm sure you're all starting to fill in the waiting room now. We'll just allow another minute or so and then we'll get started on time. Okay, we're right on 7 o'clock, and hopefully there'll be more people joining. We have a lot to cover in the next 60 minutes, so we might get started right on time. Good evening, everyone, and welcome. My name's Merrin Findlay. I'm a Fellow of Dietitians Australia and a current board member for the Australia and New Zealand Head and Neck Cancer Society. It's my very great pleasure to welcome you to tonight's webinar with the provocatively titled of Is Sarcopenia the New Smoking? Implications for Survival, Surgery, Systemic Therapy and Swallowing Outcomes in Head and Neck Cancer. We have had a phenomenal response to this webinar. We have, as of this morning, 520 something registrations. So we're absolutely delighted to have so many people joining us from around Australia and New Zealand this evening. Tonight's webinar is proudly brought to you in association with the Head and Neck Cancer Australia. Many of you be familiar with the wonderful work that HANCA does and their important role in supporting, educating and advocating for people affected by head and neck cancer. And we sincerely thank them for their valued partnership in bringing you this webinar tonight. This webinar is supported by 40CYP Compact Protein, and we gratefully acknowledge this support in making this webinar possible. You'll see two QR codes on the screen, and you can scan the first one for complimentary product samples and the second one to reach out to connect directly with the Nutricia representatives. I know that the Nutricia team will be very pleased to connect with you and only too happy to help with your inquiries. We acknowledge the traditional owners of the land on which we gather today and the many lands on which we undertake our work. We recognise their continuing connection to these lands, water and culture, and pay our respects to their elders past, present and emerging. We have a fantastic lineup for you this evening. Tonight's topic, I think, really reflects a growing area of importance in head and neck cancer care, with sarcopenia and muscle health more broadly increasingly recognised as major influences on outcomes across the cancer care continuum. We're privileged to be joined this evening by outstanding international keynote speaker, Professor Vicky Barakos, together with an exceptional multidisciplinary panel who we'll meet a little bit later in the program. This evening we'll begin with a 30-minute keynote presentation, followed by a 20-minute MDT panel discussion, and with time for audience questions via the chat if time permits at the end. So to guide us through the evening, I'm pleased to introduce our moderator, Professor Judy Bauer. She's a Professor of Nutrition, Dietetics and Food at Monash University. And of course, some of the people online will be aware that she is one of our international leaders in oncology nutrition research, and she has made substantial contribution to head and neck cancer nutrition research. So I'll now hand over to Judy to introduce our keynote speaker.
Thanks very much, Merrin, for such a warm welcome. It's with great pleasure that I introduce Professor Vicky Barakos. She is an internationally recognised leader in cancer cachexia and muscle research. And as we all know, cancer cachexia is a debilitating condition characterised by a progressive loss of muscle. And this has been a major focus of her career. As a professor at the University of Alberta, she's developed groundbreaking research in the biology of this complex condition and really is the pioneer in this field. Her work has transformed clinical understanding of muscle loss in cancer, and she has certainly improved the diagnosis, treatment, and patient outcomes. She has a particular interest in head and neck cancer. In recognition of her outstanding contribution to cancer research, she was named to the Order of Canada in 2024. We're delighted to welcome Vicky as our keynote speaker this evening. And I will note that in Canada, it's 3 a.m. in the morning. So Vicky's looking very preppy for a 3 a.m. start. So Vicky, I'll hand over to you.
Hey, I'm calling you from Alberta, Canada, in the very early morning today. And I'm situated in the city of Edmonton, and my position in the Department of Oncology is situated in the Cross Cancer Institute, which is in our health system, the regional center offering cancer care to a catchment of about 2 million people in northern Alberta, Canada. Now, I'd like to thank Judy for your kind introduction. When I have an option to introduce myself, I explain myself this way. I'm not a healthcare professional. I'm not a dietitian or an oncologist. I'm a researcher and scientist, and my personal foundations are in biochemistry and metabolism. And for whatever reason, that graphic of pathways is actually what sits between my ears. Um, that interest was always focalized on skeletal muscle, a tissue which, through its continuous turnover, has a marvelous capacity for hypertrophy and atrophy. And if you wanted to pin my first and last ever publications, both of those have something to do with delving inside the muscle tissue to try and discover the mechanism of increased protein degradation um, during illness. This most recent has been I would say, a vast machine learning enabled inquiry into the molecular subtypes of human muscle cancer cachexia, trying to understand, in some measure, the underlying pathophysiology of the wasting condition. I came to Alberta with these competencies and had the happenstance to meet medical oncologists. And medical oncologists drew me in to study cancer cachexia now about 25 years ago. So I moved units to the oncology department. And I think the number one order of business was to develop this publication, which is, with 6,000 citations behind it, the cornerstone work on the definition and classification of cancer cachexia. And this was really needed for the reason that at the time there was a dozen different definitions bandied about, a useless environment for the diagnosis of cachexia in a way that would enable clinical practice or clinical care. And what this consisted of was locking up all known, acknowledged clinical experts on the condition, locking in the room and not letting them out until they had reached a consensus, which means things were agreed or not agreed. Below is a simple definition. Cancer cachexia is a multifactorial symptom of weight loss defined centrally by an ongoing loss of skeletal muscle mass, which can occur with or without loss of fat mass. Those tissues have had a divorce. Important to be aware of. This cannot be fully reversed by conventional nutritional support, though it can be largely or partially reversed by conventional nutritional support, and it leads to progressive functional impairment. And its pathophysiology has two major components: A, reduced food intake, and B, abnormal metabolism. So this is the lens through which I've been working on cancer cachexia in the meantime, but also the lens through which I enter head and neck oncology, where I understand there to be some concerns about wasting. And it's a bit of a mixed bag. We have certain persons in this last reference, Lancet Oncology 2025, raising a banner and going, there's issues here. We need a roadmap. We have a call out to do something about this. We have a scholarly society of parenteral and enteral nutrition in the United States just published a 65-page long guideline to deal with this issue. And at the same time, the European Society for Medical Oncology, in its clinical practice guideline on the treatment of squamous cell carcinoma of the head and neck, has a single sentence in it that even alludes to malnutrition or weight loss. The statement is, check your patient for weight loss exceeding 10% if indicated. Whatever that may possibly mean, I do not know. They do not further elaborate or clarify upon that point. So I want to talk to you about head and neck oncology, but I'd like to look at it through my cachexia lens. And I'd like to make a first major point that cachexia etiology is always complex and it's variable amongst individuals. And it's got three major components. It is, in the first instance, spawned or initiated by the tumor. So there are a group of tumor intrinsic factors which dictate the timing of onset and the degree and course of wasting, which are its primary, the anatomic site, as, for example, obstructing the alimentary tract or someplace else. Tumors have characteristic mutations, stage sizes, and their own metabolic activity. And they are famous for the overexpression of many molecules, including those I would refer to as catabolic effectors, which simply means they can do something that cause wasting to launch. So tumors can produce molecules that travel humorally to the central nervous system, shut down the appetite. Tumors can express molecules that circulate to muscle cells and provoke protein breakdown. Tumors also elicit immune responses, and perhaps one of the things we've known for the longest time about disease-associated muscle wasting is the ability of pro-inflammatory cytokines to launch lipolysis in fat tissue, proteolysis in muscle. Then there are the patient intrinsic factors to consider. Sex, wasting has a male propensity, older age, a generally polymorbid population with other conditions that may also provoke wasting, and clearly a genetic predisposition to be either resistant or susceptible to wasting in malignant disease. The treatment-related factors are huge and very prominent in head and neck because of the likelihood of patients receiving all of surgical, systemic therapy, and radiation intervention. Each one of those, in and of itself, can impair dietary intake and invoke catabolic responses. We more recently become aware as well that systemic therapies often have tissue-level specific toxicities, and I'd point to cisplatin as being has a terrible cytotoxicity direct to muscle tissue. So that's a bit of a picture of the construct. Now, I'd like to mention, this is a key point as far as I'm concerned. What I'm calling cachexia, anybody else might call weight loss, wasting, malnutrition, anorexia, cachexia, vice versa, underweight, sarcopenia, frailty, and it's a bit of a rabbit hole to get involved in debating these terms or pretending that it would be possible to attempt a differential diagnosis in a patient with cancer. So go back to Gigi Boy, who had many insights, and he's been right all along. These are overlapping concepts, and if the patient with cancer has anything, they have all of these. So try to walk past this. And that's what I'd like to next move on to is moving through this kind of debate and tried to point out to you three things that I think you really need to know in assessing cachexia in patients with cancers of the head and neck. And those three things are: how much food is the person eating? What is the magnitude and the severity of their prior history of weight loss? And what is the level of reduction of their muscle mass? I'm going to discuss all of these three things, making examples to you from patients' first visit related to their head and neck cancer. So the condition of these three elements in patients who have not yet received any treatment. And I'm going to be strongly emphasizing the severity of each one of these features. So go to dietary intake. There's fantastic clinically expedient tools that allow you to inquire of your patient in a patient-reported test, their level of food intake. These verbal anchors: normal food, normal amount, normal food, less amount, and then little solid food, only nutritional supplements, only liquids, and very little of anything, are the verbal anchors from a validated nutrition screening tool called the Patient-Generated Subjective Global Assessment. This information is invaluable. So I'd first like to point out that a proportion of patients, new patients with cancers of the head and neck, about 53% of them claim normal food and normal intake. That for them corresponds to a weight loss less than 5%, if any, and an intake north of 2,000 kilocalories per day. The claim of normal food in lesser amount is made by 25% of treatment-naive new patients in this important population-based cohort, and that corresponds to intermediate intake and a weight loss heading for 10%. Any one of these four verbal descriptors of severely reduced intake align with a calorie intake of less than 900 per day and as low as 350, and affects 1 out of 5 patients. And I'd really like to emphasize this information across the scale of severity. Being knowledgeable about the scale of intake that a person might be having would be really useful in forming a conversation about the likelihood, for example, of patients in the severely reduced class is requiring a tube during their forthcoming chemoradiotherapy. The next feature is the weight loss, and that is also capturable by a patient-reported questionnaire about current weight and weight at 1 and 6 months previously. So we know how to query the weight loss. We also now know how to properly grade it. So it's been about a decade since the consensus group from the Cachexia consensus followed up on one of their key statements, which is the importance of weight loss is related both to the magnitude of weight loss and the amount of body reserve that the person had in the first place. In this scoring scheme, a grade of 0 is conferred in the upper left-hand corner of this plot to high body weight people with no weight loss because they have the longest survival. The score of 1 goes to the next adjacent group of people who have higher weight loss or lower BMI, whose survival is significantly shorter than people with grade 0. And likewise, across this schema, common grade, common median survival. And I'd point out to you in a head and neck population, we have, before any treatment transpires, 10% with grade 4 weight loss, 19% with grade 3 weight loss, as well as lower grades of weight loss. This grade 4 weight loss in head and neck oncology patients aligns with the median survival of only about 11 months. So this, again, the scale of severity is really important to appreciate. Next, the muscle mass. So radiologically, using cancer imaging, it's been possible to go into any patient population. And in this case, it's 1,231 consecutive in our Alberta population-based cohort. Taking people of either sex, there is a distribution of muscle mass, which is rather broad. This distribution is for men. The least muscular folk in this distribution have around a third as much muscle as the people at the top end of the distribution. And that distribution aligns with an adjusted hazard ratio for death, which is pretty flat across the highly muscular persons, and then upticks significantly and then goes off like a rocket. So we feel that this is usefully classified as sarcopenia in 2 grades. So to avoid using the S word, at the first uptick of significantly increased risk of mortality, we have 24% with class 1 skeletal muscle depletion and 11% in class 2 to reflect the very highest part of this curve. And again, severity is of the essence. Class 2 sarcopenia is these people have the muscle mass of a 95-year-old walking in the door, and they're not 95 years old. And this may not be obvious, so it's very important to appreciate the severity also of this depletion. So now I'm going to put these 3 things together, and I've pointed out to you that these 3 pieces of information are prognostic or developed. The scoring is based on association with mortality. So this is a new thing we've done, but I'd like you to think about it. We're giving each new patient in our head and neck cohort a nutrition score, and it is their food intake score as normal or 2 other grades of impairment, as I've just described, the weight loss grading, as I've just described, and the muscle mass depletion, as I've just described. And putting that as an aggregate score, you can have a score of 0 if you are eating normally, have never experienced weight loss, and have no depletion of your muscle mass. And that group in this univariable analysis has a median overall survival of 144 months. Varying grades are possible for different combinations and severities of these features. The trifecta, if you like, worst food intake, worst weight loss grade, and most muscle depletion in this univariable align with a median survival of approximately 6 months. So this information is prognostic at univariable, but I think also importantly, if you then take this univariable analysis and fully adjust it for age, sex, performance status, stage by version 8 of AJCC, tumor anatomic subsites, and treatment, including surgery, chemotherapy, immunotherapy, and radiation therapy, the effect of these nutrition features is undiminished. So 2 things about this. If you're in the business of prognosticating in your patient group, I would like to suggest you may consider importing this score as part of your prognostic algorithm. That may give it great strength and add information not otherwise present. I would also like to suggest that having this information to hand, these things graded in real time at your new patient consults, along with the prognostic prediction for that person, may usefully frame your cancer care as well as your nutrition care. Now I'm going to go back to muscle and say a few things about muscle. We started doing this in early 2000s, we had a first publication in 2007 where we simply proposed to deploy standard cancer imaging to look at muscle mass. And that is a huge opportunity. We started doing that in gastrointestinal malignancies, and we picked the lumbar vertebral landmark because that was already proven to be the best correlate of whole body muscle mass. But this is the enlightenment. You could take, as the three people in the bottom row, three otherwise absolutely identical people of the same height, the same weight, the same BMI, the same apparent body habitus, could have absolutely disparate muscle mass. At the same time, three people with approximately the same amount of muscle could be vastly different in body weight as influenced by their varying degrees of body fat. So when we first got this information, I'll remind you that was in 2008, and we looked at it in a group of people who were obese, I think principally because we were hoping to understand that by the imaging you can see something you don't otherwise see because the person is so heavy, so you cannot visualize or in a physical exam detect their depletion of muscle mass. We got the muscle mass distribution. We determined the survival relationship. We treated it as a bivariate at the time to reveal this very important difference in survival. At that point, that was reasonable, but I'd again like to emphasize that at the current time, and this is the main population in which we've looked at extending this head and neck, I think it's really worthwhile to extend this to a 2-category classification of muscle depletion. In head and neck, attempting to do that has got some wrinkles upon it. So if you wanted to do this and reside and have your data comparable to a now quite vast literature, all acquired at the 3rd lumbar vertebral landmark, you can only do that in a head and neck setting if you have PET-CT, full body studies at for staging and follow-up. And that might be the case in some places, but it's certainly not everywhere. So you're left with deploying a thoracic or a head and neck series for your sarcopenia information. And while this isn't perfect, there's about 70 articles from the head and neck tumor sites where people have deployed the 3rd cervical vertebral landmark for quantifying muscularity. So no, it's not a perfect surrogate for lumbar, and it's not a perfect surrogate for whole body muscle mass. However, if in your population you have a distribution that you can describe at C3, then you can take your individual patient and situate them where they happen to lie within this distribution. I find it interesting that radiation oncologists are definitely adopting these methods. This citation is from a group at the MD Anderson Cancer Center who have been launching deep learning-based automatic segmentation in their radiation planning pipeline. So they can real-time acquire this and have the information at their fingertips. Others, interestingly, are picking up, these are just a couple of examples of radiation planning CT, to capture the dynamics of muscle loss over the course of a radiation treatment plan. So radiation oncologists are publishing in this area, but it's not just them who are doing the imaging. Medical oncologists are doing it, and oncology dietitians in several places around the world are undertaking these measurements. So there's a weight of evidence. If you go in the head and neck tumor site and look for literature, you can find in the last 18 months, 5 meta-analyses with anywhere from 2,000 patients to 14,800 patients. Two of these are on postoperative outcomes, so postoperative complications in this one and postoperative morbidity in this one. Short-term treatment-related toxicity. This is a systemic therapy in this meta-analysis, and a meta-analysis specific to nasopharyngeal carcinoma in this review. So this is being adopted, published, and done by people in head and neck oncology. And I'd like to encourage you all to not be the last past the starting gate on this particular effort. Now, if you're a medical oncologist, I wonder, when I was showing you this, what were you thinking? Because the first medical oncologists in our group that helped us do this imaging in the first place looked at this and said, wow, look at this. These are three people. They have about the same amount of muscle. And then they're people of a certain size. They about the same amount of internal organs. Difference between these people is the amount of adipose tissue they have. And they paused to contemplate that adipose tissue inflates the body mass, it inflates the BMI, and it inflates the body surface area. So that had them pause to think that someone who's sarcopenic and has a very large fat mass at BSA-based dosing is possibly likely to receive an overdose. And this hasn't been looked at in head and neck very much, but maybe if I could go back a slide, I will point out to you that there's a sarcopenia meta-analysis on short-term related treatment toxicity. But I'm going to shift you over to gastrointestinal oncology, where in adjuvant treatment of stage 3 colon cancer, oxaliplatin neurotoxicity is a terribly daunting side effect. So this group in France, in their national colorectal cancer tumor group, undertook a trial where they tested the conjecture, which I just stated. So they randomized patients in this phase 2 study to one of two groups. The standard of care arm received their oxaliplatin-based therapy dosed in the conventional manner according to BSA. In the experimental arm, it was dosed relative to lean body mass. So it's ignoring that fat mass inflation and scaling down the chemotherapy to be more aligned with the lean tissue, which is about 75% muscle. And this gave them a very powerful result. It was published in the Journal of Clinical Oncology last fall. This time to event analysis is the oxaliplatin-induced peripheral neuropathy free survival, which was less common in the lean body mass based dosing, and it occurred later. For that reason, the French medical oncologists have entered this as a recommendation in their 2025 clinical practice guideline. I don't know if this will fall out in head and neck oncology, but I'm showing you a direction where now the muscle mass and body composition is being seriously considered to adapt cancer treatment. So the last place I'm going to go, and this is going to be a brief section, the functional implication of muscle loss is really important. And I'd like you to understand that cancer-associated muscle loss is widespread. So everything that makes it happen, malnutrition, inflammation, chemotherapy, all of these things, their effects are systemic. So there's not a whole lot of evidence for specific local regional muscle loss. It's just everywhere. But you might expect someone with that class 2 sarcopenia may enjoy all of these things, which have been documented in patients with different cancers. So in the lower limb, muscle loss aligns with strength in the lower limb. Respiratory and accessory respiratory muscle loss aligns with reduced FEV1, and exertional dyspnea in people who've got absolutely nothing wrong with their lungs. So that dyspnea is attributed to the loss of respiratory muscle mass. Cardiac atrophy has been shown. These are data from non-small cell lung cancer in platinum-based therapies, and that's associated with a functional change in the global longitudinal strain determined by echo with preserved ejection fraction. And there's an interest amongst you and an interest out there as well on sarcopenic dysphagia, which, if I understand the thought behind that, would be similar to the respiratory muscle loss, is that the muscles of mastication and swallowing could be so sarcopenic that in and of itself becomes a factor contributing to dysphagia. So now I'm going to stop and let you off the hook. Long before people knew any of the biological basis of disease, they understood the importance of assessing the characteristics of the person affected by the disease. Whatever the things that I've thought of doing, these can hardly be credited as original ideas. And I think the ancients knew something that we can now seek to remember and encompass in our ongoing efforts to appreciate the diversity of the human body, of their weight, how their weight changes throughout their lifetime in the course of the different diseases they may experience, and how uniquely muscle and adipose tissue within any person's body are distributed, and how they change and evolve over the course of their experience of the disease that we call cancer. Thank you so very much, and I'm looking forward to hearing your questions and thoughts.
Thank you so much, Vicky, for that wonderful, wonderful presentation. We're going to move straight to the multidisciplinary team presentation, and just wait for Merrin to start screen sharing. Thank you very much, Merrin. So with us tonight, we have a fabulous team. So we have Merrin, Associate Professor Merrin Finlay, who's a dietitian, Associate Professor Brett Hughes, a medical oncologist, Clinical Associate Professor Felix Sim, an oral and maxillofacial surgeon, Dr. Matt Wallen, a Senior Research Fellow, an exercise physiologist, and rounding out the team is Rishni Piera, a PhD candidate and speech pathologist, as well as our keynote speaker, Vicky. So I'm going to start off, and perhaps, Vicky, I'll ask you the question. So do you think sarcopenia is a new smoking?
Is the new smoking, in the sense that we've appreciated the impact it has on the person and the way that intersects with the treatments of the person with cancer. And I, in some way, blame myself for dumbing it down to a bivariate. I think treating any condition as a yes/no underserves the possible severity of that condition. And I think that's the hump we're going over right now, is the discovery that you've got 10% of patients with egregiously wasted muscle before anybody has given them any cancer treatment. And there's people who, and those people are going to visit deeper, worser losses on those individuals, transform people who have no sarcopenia to have sarcopenia and to cause it to worsen over time. And then if you're the SLP, and you're trying to help the person with swallowing and other aspects of their physical functioning, and you're completely blind to their sarcopenia status, um, you are asking something of your rehabilitation that may need to be adjusted to the degree of muscle wasting that they've already experienced.
Thanks, Vicky. So I might open a question for the multidisciplinary team. So from your perspective, what does best practice look like for managing sarcopenia in routine care? And we might kick off with Merrin.
Thanks, Judy, and thanks, Vicky, for a wonderful presentation and a really very profound overview of the enormous impact these both sarcopenia and malnutrition are very much occult conditions. So we're also in an era of obesity where these things are not always visible. And one of the really key elements of nutrition care being best practice is early identification of problems that are not necessarily visible at the start. I think best practice nutrition care works when we are acting in a proactive versus a reactive way and having a systematized approach to early identification so that we have systems and processes in place for screening, and we have validated tools for screening for malnutrition and sarcopenia. And then also moving on to a systematized and systematic way of nutrition assessment. And Vicky's very kindly alluded to really our gold standard for malnutrition assessment in the clinic, which is the patient-generated subjective global assessment, which, as we've seen, delivers some very powerful information about a person's prognosis. We just need to be routinely putting it into practice. The second part of that is effective nutrition interventions, and particularly drawing attention to the need for adequate energy and adequate protein. I think we have a whole lot more information about the importance of that in synergy with the exercise component, and I'm sure we're going to hear about from Matt in a little while. And then lastly, the importance of ongoing monitoring. We meet people, we follow them for many months throughout their care trajectory, but they change rapidly. And so the importance of reassessing and adjusting our intervention is actually very important. And then probably the last thing that I would touch on is the importance of, in best practice, the importance of communication amongst the MDT. Not just as patients sort of flow between the different care stages from, systemic therapy to surgery and in inpatients, outpatients, but as they flow through their care trajectory. So they become, discharged and they flow home to community settings. In Australia and New Zealand, we have regional, rural, remote, vast distances at times. And I guess just making a shout out for the importance of continuity of care and the role it has in best practice. So that's my sum up for nutrition, Judy.
Thanks, Merrin. Matt, exercise best practice.
Thanks, Judy. And thank you, Vicky, for that wonderful talk. I think you could basically replace nutrition with exercise after what Maren said, and that would fit quite nicely with screening, assessment, intervention, follow-up, and also patient management and communication. I think one of the big things from an exercise standpoint is really looking at what are the priorities that we're aiming to address. And sarcopenia in itself is a challenging thing, particularly from an exercise standpoint. But certainly when it comes to exercise, it's one of those unique aspects where it's an anabolic stimulus that can actually promote preservation of muscle, which is probably the priority in this particular cohort, particularly leading to treatment, during treatment, and after treatment. But unlike a lot of other interventions, exercise needs to be done regularly in order to actually have good effectiveness. And as Maren highlighted, this needs to be done in a very targeted way in alignment with nutrition interventions. We know that exercise promotes energy expenditure, so we need to take care when we're actually prescribing exercise in that particular way. One of the things that is important to recognize as well is that exercise has different modes and different intensities, and and other sort of tailoring aspects that can happen. And one of the big advocacies that I've been really pushing for is around not just focusing on just going for a walk and the messaging of staying active, is that exercise needs to be a medicine and prescribed like a medicine. So things like resistance training done in a very intentional way to overcome these factors is really, really crucial.
Thanks very much, Matt. So moving on to medical and surgical best practice. Felix, what's your thoughts about best practice, and do you currently feel in the dark in relation to muscle mass status?
Sure, definitely. I certainly learned a lot in that last 30 minutes of presentation by Vicky, so thank you very much for that. And I guess having my surgeons cap and representative of surgeons, we would acknowledge that I think we under recognize the whole sarcopenic kind of a status of a patient. We have very crude ways of being able to identify them, but it's not very much data driven. It is not validated. You know, it's the ones that when you identify the patients coming in, because they were the ones usually seeing us in the first time, how frail they are, how can they get walking from the waiting room to consult room, how can they get up, and so they're the kind of key indicators. And beyond that, we ask them about nutrition. So I would support Marin's kind of first point is early identification and providing us with probably better tools to actually objectively measure that. And once the patient gets to an MDT setting, we have the dietitians, and at Melbourne Health, at Royal Melbourne, we've got a great team where in that first appointment, they're seen by the speechies, the dietitians. But even before that, it'd be great because you can have an opportunity to optimize their nutrition even before they get to that first meeting.
Terrific. Thanks, Felix. And from a medical oncology viewpoint, Brett.
Thanks, Judy. And I would also echo that Vicky's done an excellent talk. I did feel like medical oncology was a little bit of the target of the systemic therapy bashing, but that's okay. I would highlight, also echo Felix's point that I think multidisciplinary assessment and care for these patients is critical. I would say, though, that I think sarcopenia is probably a lot more hidden than what we recognize for smoking. So if we sort of think about it as the new smoking, this is probably really something that sneaks up on clinicians day in and day out, and perhaps is under-recognized as a reason why patients might be borderline for tolerating therapy, whether that be surgery, radiation, chemotherapy, or a combination of all of those things. One of the key things that I think for us, and I've been saying this for many years, that I think dosing for chemotherapy in particular is a fairly arcane science. And Vicky's touched upon this, that it's very much a sort of, how big is the patient? And then that's how we're going to dose them. There's not a lot of nuanced or subtlety to that. And really, I think as a profession, hopefully this is a sort of impetus that we can move forward with more personalized dosing. I think one of the other things that from a medical oncology perspective that we're about to embark upon a new paradigm of incorporation of immunotherapy and curative patients, particularly with perioperative treatment. And so that's really going to change the landscape, I think, both in ways that we have to think about how immunotherapy might affect either risks for sarcopenia or patients that already have sarcopenia, but also potentially enabling us to de-escalate their adjuvant treatment. So either lower dose of radiation, potentially less chemotherapy, less combination therapies might also help to really not exacerbate that risk for sarcopenia. And then moving into the recurrent metastatic setting, again, I think dosing of patients is important, and thinking about lean muscle mass and ideal body weights might be a better way to dose some of our systemic treatments rather than body surface areas and BMIs. But general fitness for patients, often sarcopenic patients, are ones that we might intuitively identify that they're going to be at risk of toxicity with treatment, or perhaps we feel that they're not even fit for treatment. And then how we intervene to make either that treatment an option for those patients or as safe as possible to give them the best outcome. But it's interesting times ahead.
Mm-hmm.
Thank you.
Rishni, so moving to you, what's the literature currently telling us about sarcopenia and dysphagia? Because I think that's a fairly new area for speech pathologists.
It is, Judy. So as part of my PhD, I conducted a scoping review that looked at this relationship between sarcopenia and dysphagia in head and neck cancer. And I found about 12 articles that explored this association. And out of that, 10 did say that there is a positive association between sarcopenia and dysphagia. So what that means is when someone has pre-treatment sarcopenia, they are at risk of having pre-treatment dysphagia. And if they have pre-treatment sarcopenia, they are also at risk of having post-treatment dysphagia, leading to consequences like restricted oral intake, long-term feeding tube dependence, and high rates of aspiration pneumonia. In one of the studies, they even looked into a bidirectional relationship where post-treatment dysphagia was identified as a risk factor for worsening of post-treatment sarcopenia about 3 months after the treatment. So there is definitely evidence to show that there is a association between sarcopenia and dysphagia. But as I said, I only found 12 studies. So the literature is small and quite heterogeneous. And I think Vicky alluded to some of these points in her presentation earlier as well. So there is differences in the tumor sites and the treatments, patient populations, that makes it harder to compare between the studies and come up with definitive conclusions about the association. A big difference is the measurement of sarcopenia. And most of the studies derived sarcopenia looking at CT scans at the level of C3. However, there were differences in the cutoff values they used and the calculation formulas, making the diagnosis variable, the definition of sarcopenia variable, and comparing hard. Similarly for dysphagia as well, different diagnosis methods for dysphagia using a range of clinician reported measures, surrogate measures of dysphagia, a very small number of instrumental assessments. So because of that, there is a lot of heterogeneity in the current literature. But I think it is very important for us to start recognizing this relationship, sarcopenia and dysphagia, in the management of head and neck cancer patients. Start paying attention to this as an important risk factor as the evidence base builds up in this area.
Thanks very much, Rishni. So I'll return now to you, Vicky. So what do you think is the most important next steps to embed muscle health assessment into routine head and neck cancer care?
Well, sarcopenia is like osteopenia. But osteopenia is a diagnosis that enjoys governance of the colleges of radiology. So it has governance, and in exactly corollary to the way we treat reduced muscle mass. Radiologists come together and defined an international standard for the definition of osteoporosis and osteopenia based on radiologically determined reduced bone mineral density. And that does not exist for sarcopenia, so it doesn't seem to be in the purview of the colleges of radiology. And as Rishni points out, it's being done every which way by anybody. And I don't think you can sit around and wait for some governance body to magically appear. But what you can act on is what's specific to your cancer center. So you could local regionally, like these people at the MD Anderson Cancer Center, decide that you're going to deploy your radiation planning images, buy yourself a segmentation, hook it up to your imaging systems, and you have this information at point of care. You can decide to do that. I also, maybe I sound sarcastic when I'm saying don't be the last to cross the starting line on this. The IAEA, the International Atomic Energy Agency, is in the middle of delivering a call for proposals that will, it's restricted to low and middle income countries that will, and it's in head and neck, and oncology that will enable people in the Philippines and in African nations and other developing countries to have this imaging pipeline in their centers around the world. And so different people and organizations are deciding this is important for them and they're doing it. And they can take their population, define the distribution of features that they think are important, link them into the outcomes that are important for them in their setting. I think it's doable. You have to decide to take that initiative.
Thanks very much, Vicky. Look, in the interest of time, I'd like to thank all of our multidisciplinary speakers for giving their great perspectives this evening. I'm going to hand back over to Merrin to finish tonight's presentation.
Bear with me, folks, while I find between Zoom and Teams, get familiar with how everything works again. Look, don't run away in the final few minutes. I really would just like to say thank you to Professor Vicky Barakos and to Professor Judy Bauer for their keynote and moderating skills, and of course to our multidisciplinary team for the panel discussion. Look, it really is the tip of the iceberg. I think we could talk for many, many more hours about the really fascinating topic that we've covered this evening. To give you something practical to go away and think about what can you do and how can you apply this in the clinic room starting tomorrow, is to make you aware that there are a series of evidence-based guidelines, in particular the ones Judy and I have led the synthesis of for the last 15 years now, the COSA Head and Neck Cancer Nutrition Living Guidelines, and also our COSA Cancer-Related Malnutrition and Sarcopenia Position Statement, for which we've also produced phase 1 and now soon to be phase 2 of an implementation toolkit. Whether you're an oncologist, a surgeon, a nurse, or an allied health professional, there's something in that toolkit for everyone. And really, I guess the key message is we're trying to make this easier for people to put evidence into practice. I would like to give a shout out to our Victorian colleagues. They have some wonderful co-designed resources for prep for RT and prep for cancer surgery. And if you're not aware of those, I would encourage you to look out for them. And it's also an opportunity to mention for those that are interested in building their capability in this really important area. I really wanted to highlight the body composition assessment by CT course that we've been developed in collaboration between Judy and her team at Monash and Vicky and her team at University of Alberta and myself. And we're supporting clinicians and researchers in accurately assessing muscle mass from CT scans. It's now a self-directed course, and you can see more details if you follow the QR code link there. Once again, we'd like to say thank you to the Head and Neck Cancer Australia for allowing us to bring this webinar to you, and also their ongoing support of people affected by head and neck cancer. We'd also like to acknowledge and thank Fortisip Compact Protein and Nutritia for their supporting of tonight's event. And again, you'll see the 2 QR codes there if you'd like to request complimentary product samples or to connect with a Nutritia representative. They would be more than happy to hear from you and help you with your inquiries. Now, I cannot let you go without drawing your attention to the fact that there are 2 more webinars planned over the next couple of months. On the 20th of May, perioperative immunotherapy in locally advanced head and neck squamous cell carcinoma, and Brett Hughes will be featuring in that webinar again, I believe. And there's also in June a multidisciplinary care in reconstruction after head and neck cancer surgery. So watch the social media for dates announced for when registrations will be open. Now, importantly, I hope it's already on your radar. The national conference this year is a joint event with the International Federation of Head and Neck Oncology Societies. It's the 8th World Congress of IFNOS in Brisbane. There are, I think, 200 speakers, 9 plenary sessions and 21 concurrent sessions. So it's really like the Olympics of the Head and Neck Oncology Society meetings. Please join us in Brisbane. Early registrations close on the 9th of June. And it's also an opportunity to encourage you to consider joining the Society. The membership really supports multidisciplinary collaborations and is a really valuable community of practice for head and neck cancer care and research. I know that there's actually a lot of dietitians online tonight, so I'd like to personally extend an invitation to you to join us. Much of their high quality head and neck cancer nutrition has actually been led by Australian dietitians, and it's something that we love to build on that strong foundation and forge a growing community of practice and future collaborations. So please don't be shy, reach out. We'd love to hear from you. And of course, we also need to encourage the support for the important work of the Research Foundation. It plays a very important role in enabling future research and innovation and better outcomes for patients. So please consider a tax-deductible donation towards the important work of the Foundation. And finally, a sincere thanks to the Society, to Head and Neck Cancer Australia, to 40-CYP Compact Protein and Nutricia, to Professor Vicky Barakos. Thank you for the untimely hour of 3 a.m. delivery of a very compelling presentation and hopefully the start of many more conversations and collaborations. To Professor Judy Bauer for moderating, to our MDT panel, and of course to all of you joining us here this evening. There is one more thing I would like to request. We have a brief evaluations survey. So to have such a high registration, we'd love to really just take 30 more seconds of your time. And it allows us to meet the education needs of our members of what to offer for future webinars. But we hope you found it tonight informative, practical and inspiring. Thank you to all of you for joining us, and good night.
Night.